if a hospital breaches OSHA.
You get fined, you could be shut down.
Exactly. You can be fined and the hospital can actually be shut down. Which means, of course, you lose OSHA, you cannot be a hospital anymore. So what kind of things does OSHA do?
Inspections.
Who are they meant to protect?
The workers, right, and the workers.
Healthcare workers mainly, yeah. So they lay down the rules or the laws of under which we as healthcare providers work as far as health and safety is concerned. So they're the people who tell us they're the people who give us the regulations about what health and safety is and what we have to follow. For example, we talked about universal precautions. So let me just put this on. This is a PowerPoint from OSHA Region 6, which is Texas, but it will give you an idea of what you're working with. She says before. Coming up, okay. Let me just. So. Objectives, so we've got bloodborne pathogens, OSHA standards, employer responsibilities. So, bloodborne pathogens. Pathogenic microorganisms that are present in human blood and other potentially infectious materials that can cause disease in humans. In other words, they're the diseases that are carried in blood that can affect people. So pathogens include but are not limited to hepatitis B or HIV. Give me a few more. Anybody know any more? Bloodborne pathogens? Well, you get hepatitis B. What about hepatitis A and hepatitis C? Are they bloodborne pathogens as well? Yeah? Okay, yeah, they are. But the majority of the ones that we would be concerned about in the hospital or in a clinic would be Hep B and HIV. And it's actually more common for a healthcare professional to be infected by Hep B than HIV. Something to think about. So this is the standard that we're working on. Started in March 1992. All occupational exposures to blood and other potentially infectious materials. 5.6 million healthcare workers at risk of exposure to bloodborne pathogens such as HIV and Hep B. That's scary, isn't it? How do we deal with it? What do we do about it?
Hep B we have vaccination for.
Yeah.
HIV other than like the cocktail, I don't know.
Hep B you can, yeah, and that's why most clinics and or hospitals mandate that you have a Hep B vaccination. Because it's actually, as I said earlier, easier to get than HIV. What's the main cause of bloodborne pathogen exposure in the hospital or clinic?
Needle stick?
needle sticks. Has anybody seen a needle these days? They have this fancy cover that goes on, so you shouldn't really be able to stick yourself, but it does happen still. Okay, what would you do? Employee falls, sustains cut to scalp, fair amount of bleeding. So you're walking along the hallway, somebody trips, falls, crashes their head on the floor, and they cut their scalp. What do? You're a hospital employee, you're a healthcare professional. What do?
Put on gloves.
Pardon?
Put on gloves.
Call for help.
Call for help, yeah. How would you do that? Just out of interest, do you yell help?
Sure, that's your best method that you
If
have.
you're not near a phone where you
Yeah.
can call a code or something.
Right.
or-
Well,
not code, but for help.
do you need to call a code?
They're not coding, if they're just bleeding.
Okay, so they're bleeding, okay. So you call for help. This person is lying on the ground, he or she is bleeding. Do you do anything for them? You just sit there and watch them bleed?
Stop bleeding.
How do you do that?
Pressure.
With what?
Code? If you can have
Anything.
one.
Anything sterile?
Not even sterile. You're in the middle of a hallway in a clinic or in a hospital. Where are you gonna get sterile stuff?
Use whatever you can.
Use
find.
whatever you have, except your hand. As a last resort, you probably could, but it's probably not a good idea. So you're wearing a white coat, you're wearing a white jacket. Take that off, put it directly on the cut, and then what?
Pressure.
Pressure, thank you. Pressure, you hold it there until either they stop bleeding or someone comes to help, like a physician or a nurse or somebody with some first aid equipment. Or you could, if you're close enough to the ER, you can put them in a wheelchair and take them down to the ER. Occupational exposure, reasonably anticipated skin, eye, mucous membrane, or parental contact with blood or other potentially infectious materials that may result from the performance of an employee's duty. Direct patient care, which is what we do, or you will be doing. Phlebotomy and lab. What's phlebotomy?
Blood. Taking blood.
Taking blood, okay. And lab would be any other, like urinalysis or blood chemistry or anything like that you work with blood and body fluids. Environmental services. Who are the environmental services?
Like clean up.
They're cleaners, yeah. So if you had a massive spill, somebody vomited all over the floor, or somebody bled all over the floor, that's the people who you would call, usually. They don't like it, but you call them anyway. Waste management. Why would they be included in occupational exposure?
It's like, you might
Say it again? Say again? Who said that?
They might handle biohazardous waste.
Yeah, okay. So most waste in a hospital is considered contaminated. Doesn't matter whether it's a doctor's office and it's a wastebasket, or it's in the radiation therapy treatment room. Everything is supposedly contaminated, so that's how it works. and other. So what other things can you think of that people might come into contact with? Contaminated or occupational exposure? Anybody?
I mean, pretty much any kind of bodily fluids are possible.
Yeah, so who might be, you're looking for other
Nurses,
personnel, what?
nurses.
Well, nurses, we kind of direct patient
Oh,
care, right?
Hmm.
What about the receptionist sitting at the front desk and the patient comes up and she has a bad cough and she coughs on them? Is that occupational exposure? Yeah. These days, everybody wears these, but, 2 years ago, would you wear one of these? No. Unless you were treating a specific type of patient. So basically, anybody within the hospital area might have a problem with occupational exposure. Okay, all job classifications in which the employees in those classifications have occupational exposure. All tasks and procedures. So, schedule and method of implementation for this exposure control plan. You have to know the methods of compliance. What are you doing to avoid the exposure? If you have a patient who has a particular problem, you're dealing with that problem by using PPE, which are, everybody knows what PPE means these days, but
Gowns.
Personal protective equipment.
thank you, personal protective equipment. And it really does depend on what you're doing, what you use. Now, everybody these days wears masks. But normally, if we ever get back to normal, we wouldn't be wearing these normally. What would we be using on a daily basis when we treat our patients? Gloves. Non-sterile gloves, just examination gloves, like you guys put on. Hep B, vaccination, post-exposure evaluation, follow-up for any exposure. Will you always know if a patient has Hep B or HIV for that matter? Will you always know? No, you won't.
Treat all of them as if they have it.
Treat all of them. That's what universal precautions is. Treat everybody the same way. If you use gloves for Mr. Smith, then you use gloves for Mr. Brown. Communication of hazards to employees. You have to make sure that everybody knows what they're supposed to be doing. Because it's no good penalizing someone if nobody told them or told them that they were doing something wrong. And record keeping. That's where the ubiquitous incident forms come in. We use incident forms for things that go wrong, for things that might go wrong. There's two types of incident forms normally in a hospital, especially in a hospital. There's one which is an incident, actually three forms. One which is an incident to a patient or involving a patient. One which is an incident that involves staff. And one which is called a near miss. The incident involving a patient, well, that's sort of self-evident. If something goes wrong and the patient is involved, then that's the form you put in. If something goes wrong and it's just staff, somebody knocks their head on the machine because somebody's rotating the machine and they don't look where they're going and somebody walks underneath it and goes thunk. That's the staff involvement. So can anybody tell me what a near miss might be? It can be in various areas, but what would you think a near miss might be?
Something that could have ended badly, but you caught.
Yes, so anything really that if it didn't get caught would have caused harm, usually to the patient. So for example, you've got two Mr. Smiths, Lord help us, okay? And both of them, one is a pelvis, one is a chest, thank goodness. So you call Mr. Smith in for his treatment. They're both deaf. Mr. Smith gets up and wanders in behind you. And you just say, okay, Mr. Smith, get on the bed and we'll get you going. And you get him on the bed, you look up, you look at the picture, and you think, Mr. Smith, would you mind getting off the bed again? Or you change who you're going to be treating next because the wrong Mr. Smith came in. You go outside, you take Mr. Smith off the computer, you put the other Mr. Smith on, and you treat him. That is a near miss. So the procedure for evaluation, circumstances, immediate availability for exposed employees to confidential medical evaluation and follow-up, and documenting the route of exposure and the circumstances under which the exposure incident occurred. So, what would you think happens in a department of a hospital or clinic if the staff member had a needle stick? What do you think is the route that this staff member has to go? What would be the first thing? Where?
The wound.
I'm talking about where in the hospital would the staff member go to? Usually it's the ER. If they're in a hospital, it would be, you tell your supervisor, he or she sends you to the ER with a form filled in by the physician, a physician, doesn't matter who, saying that they've been exposed. They do a blood draw in the ER. Then what? They start on prophylaxis. What do I mean by prophylaxis?
Preventative measures in case you were exposed to something.
So what would, if you think that the patient, if you have a needle stick, you've got two things normally that you would be wondering about: HIV, Hep B. So normally what they would do is, obviously, hopefully you've had a vaccination for Hep B. But you may be one of these people who declines. In some departments you're allowed to decline, in other departments you're not. So we'll say we're testing for HIV. So the prophylaxis would be that you be started on the drugs for HIV until your results come back.
Doesn't it take like
6 months or so for those, even to be able to tell if you've got HIV?
Yeah, so they'll keep testing you until they're sure. But you still have to do your prophylaxis. The other thing you have to do is the patient will have to be tested. And a note will be made of the patient's name, the diagnosis, if they know if they're HIV positive, or a note has been put on the chart if they're HIV positive or not, but they will be tested as well. So that's why we say, please don't get a needle stick. So that's in a hospital. What about a standalone clinic? What would that be?
Would you have to leave to go to a different hospital?
It depends. Sometimes there's an occupational health nurse who would be available to do this stuff. Then the testing would be done in a hospital clinic, a hospital. But normally there'd be somebody there who can either do it or they'll send you to the local ER. Okay. Standard or universal precautions. Notice it says shall, which means you must. So, standard or universal precautions shall be observed to prevent contact with blood or other potentially infectious materials. And all body fluids shall be considered potentially infectious materials. So, blood, urine, feces, saliva, anything else?
Vomit.
Vomit? That's about it. And even a cough. Especially if you have mucous membranes involved. So if they cough into you get it in the eye, that can be a root. Also, if you have a small cut on your finger or hand where something might just sneak in, so any cuts or breaks in skin should be covered, even if you don't have gloves on. Are gloves all-encompassing? Are you safe if you're wearing gloves? As far as touching stuff?
Relatively, but there's no 100% that it's gonna keep you safe.
Okay,
There could be a micro tear in it, you could recognize it
Right.
there.
okay. That's why a lot of physicians, if they're doing internal exams on patients, will double glove. So yeah, gloves are important, but they're not the be all and end all, okay? So, the purpose of work practices. Eliminate or minimize employee exposure. Sometimes you cannot eliminate. You may have to just minimize. Readily accessible hand washing facilities. Contaminated sharps management. Food and drink out of the work area. Procedures having blood handling. Transport of specimens of contaminated equipment. Okay, so hand washing facilities. Each treatment room that you'll be working with will have a sink with soap and water, obviously. Well, maybe not obviously, but they will be there. They'll also have this stuff. Which is better?
Sink and soap.
Pardon?
Soap and water.
Soap and water. Always if you can get it. What's the problem with using this stuff? Or the big stuff? What's the problem with using that?
It only kills 99.9.
Yeah,
It kills the germs, but they're just chilling there on your hands still.
if you, yeah, if your hands are markedly dirty, will that stuff work?
No.
No, you good old soap and water. It's actually better to use soap and water if you can get it. If not, use that stuff for maybe 3 or 4 times, then wash your hands in soap and water. Tell you a story. I went to get my fingerprints taken. Nothing serious, just I needed some paperwork done, so I needed to get my fingerprints taken. And I went down to the local sheriff's department because they were the ones that were going to give it to me. And of course, they have the new electronic stuff where you put your fingers on the light and put them on and does it automatically in the computer. And I did that, and the guy looked at me and said, your fingerprints don't look very good. And I said, okay, I don't know whether that was good or not. So he tried it, and he said, let's do it again. So they wiped my hands with whatever they do, I think it's alcohol or something. And we did it again. Same thing happened. And he said, I'm sorry, I can't put this through the computer. We're going to have to do it the old-fashioned way. So out comes the ink, and we did it the old-fashioned way. And once I had cleaned out my hand, and he said, may I have a look at that? And he looks at my hand and said, does this? I said, yeah. And he said, you work in healthcare, don't you? And I said, yeah. And he said, how long have you worked in healthcare? And I said, well, and this kid is about, 25 or so, I said, probably longer than you've been alive. And he looks at me and he says, use a lot of hand gel. I said, yeah. He said, that's why. The hand gel destroys the outside layer of, well, it doesn't destroy, but it wears away the out layer of the skin easier than soap and water. So, just a little story. So every time I have to go, if I have to go and get my fingerprints taken, I have to tell them that the electronics thing won't work, but of course they do it anyway. So if you can, moral of that story is, if you can, use soap and water. Of course, if you're going to be in the field for 30-something years, then yeah. We always had these things outside of the room, so every time we came out, we'd grab a little bit and wipe our hands and everything was good. So, keeping food or sharps management. What do we mean by sharps?
Needles,
Needles.
utensils, anything that can pierce the skin easily.
Not even easily, but anything. So what would that include? Needles? Needles is the obvious one.
Scalpels, surgical
Scalpels.
scissors.
Syringes also. So they go into what is called a sharps box. And you'll see them sitting on the walls of the treatment rooms, in the CT rooms, and that's where you put all your sharps. They're red. Keep food and drink out of the work area. Easier said than done. The drinks, yeah. Unless you have a drink container that is unspillable, if that's it. Anyway, something that if it tips over, it doesn't spill all over the place. So no cans, no bottles of water, nothing. Well, is that an unspillable container? No. So there's nothing here that would, if it tipped on its side, that one is, okay. That's because you have it locked down, right?
No, it's a screw top, it's all the way on, it's screwed all the way down.
Okay. But if you had to drink it, what would happen? What would you do? You'd unscrew it and, yeah. So theoretically, if you talk to the infection control nurse, whom one of my physician friends used to call the infection Nazi, would come down and look at the department and she'd say, get rid of that, get rid of that, get rid of that, get rid of that. Because we were having a joint commission. Everybody heard of joint commission? We're having a joint commission visit in a couple of days, so she was getting hyper. Oh, when she got hyper, she got really hyper. So she'd come around and of course the patients would come in and they would bring us boxes of chocolates or fruit or whatever it happened to be. So of course we would have them sitting there so the patient would know that we were taking advantage of it. But no, that had to go too. So we'd put them in a drawer. And every so often we'd take the drawer open. But yeah, so no food or drink in the area, treatment area. Why is that? They're not trying to be, well, she was, but they're not trying to be officious. What are they trying to do? What's their job? They're trying to keep food and drink out of the work area because
Prevent contamination.
contamination, cross-infection. Same as flowers. Patients would bring in these beautiful flowers or plants or something and we'd put them up in the area, usually in the waiting area. Is that a good thing or not? No?
Probably not.
Probably not.
Smelling
Why
flowers
again?
especially.
Cross-infection. The next three, we probably wouldn't, well, the next two, we probably wouldn't get involved with. If we needed to send someone for a blood test, we'd send them elsewhere, to the lab within the hospital or the lab within the department. Same as transport of specimens, we would very rarely get involved in that. The only people that might get involved in that is our nurses. But we would never get, unless I had a patient who brought in, he was complaining of diarrhea. Yeah, you're ahead of me here. And we had told him, or the physician had told him, to try kale pectate. So, what's kale pectate? Antidiarrheal. So he stupidly said, let us know how it works. So the next 3 or 4 days later, the patient comes in and takes this little baggie out of his pocket and says, I just wanted to bring this to show the doctor, and plops it on our desk. And we looked at it and said, okay. Thankfully enough, it was sealed. So we grabbed, we had some biohazard bags. So we got this little baggie and got gloves on and put it into this biohazard bag, and one of the students got sort of, please take this up to the nurses and tell them who it was from. So we very rarely get that, but sometimes we do. Not very often. And contaminated equipment. If you're treating a patient who has, for example, MRSA, everybody's heard of MRSA, MRSA, or C. diff. If they're lying on the bed Does that contaminate the bed? Even though there's a sheet over the top? If you put a sheet over the table, patient lies down, then obviously the sheet's contaminated, but you have to treat the bed as contaminated as well. And anything the patient may touch, you probably want to decontaminate as well. And that's when the bleach comes out. So anything the patient touches, whether it be the little step stool that the patient has to get up to get onto the bed itself, etc. Teaching appropriate technique. Make no assumptions. We can always say, use common sense. People as a rule don't have common sense. In all seriousness, they don't. So you have to take it step by step and make sure that you know, or the person whom you're dealing with knows what is supposed to happen. There's a technique which is called clean and dirty. So you have two therapists. One is clean, one is dirty. That sounds weird, but anyway. What that means is the clean therapist handles the bed controls and the hand controls. The dirty therapist handles the patient. So they get the patient on the bed, lie them down, get them positioned with the lasers, and the clean therapist would raise the bed, check everything without touching the patient. If, however, the patient needed two people to help them on the bed or to help them position, then a third person would have to be involved, because you need to keep one person clean.
So when you go in in the morning, do you flip a coin, does it use dirty and clean?
Well, it depends on what kind of patients you have. If you have no patients, then you don't have to. Each person can handle themselves. But if it's someone that has MRSA or C. diff or any kind of infectious disease, then you certainly have to do a clean and dirty. So the clean person would handle the hand controls, handle the bed movements, anything that doesn't involve touching the patient. And then she would come out, pull the door, let the dirty people out, pull the door to, set the controls on the outside onto the control area, treat the patient, and then the door would get opened and the dirty people would go in, take the patient off. And they don't really, the clean person, because she is handling the controls outside, she would take her gloves off. The dirty people don't have to. They can just stand there like lemons with their hands like this, because they don't have to. They're not touching anything. Does that make sense? Okay. So, availability of materials. So not only are we interested in that, but we're interested in things like reading materials to make sure that everybody understands what they're supposed to be doing. And reinforcing, and reminding, and monitoring. You have to make sure that everybody knows what you're supposed to be doing, and you have to remind people, because people forget, people get busy, they don't think. they do something that they're not supposed to. Okay. Alcohol-based hand cleansers in multiple locations. Monitor use by volume, replacement, and observation. When they should be used, if hands are not visibly dirty, if soap and water are not available. If soap and water are available, wash your hands. If it's not available, this stuff. Washing with soap and water, 20 to 30 seconds if hands are dirty and after direct contact with potentially infectious materials. After toileting and caring with a patient with a C. diff or a MRSA infection. Always. When you're using this, how much should you use?
More than you want to, for sure.
Yeah,
Enough to cover.
enough to what, cover your hands?
And then have to keep doing it for.
And you basically do this. You don't just do this. You basically, as if you're washing your hands, right? Until the hands are dry.
The big one, your hands will never be dry.
I know, I know. Okay, so obviously for OSHA, we can get posters, we can get fact sheets. So, personal protective equipment, or PPE. This has been in the news so often that probably everybody's sick fed up of this stuff, but we'll do it anyway. Shall be used, notice shall be used when exposure remains after institution of engineering and work practice controls. Employers should provide appropriate PPE at no cost to employer. May include gloves, gowns, lab coats, face shields, masks, eye protection mouthpieces, resuscitation bags, pocket masks, or other ventilation devices. Majority of the time, gloves. If you have somebody who is coughing, then you might want to use gloves and a mask. Face shields are all the go these days. You don't really need them unless you've got someone who's coughing this way. Or eye protectors, goggles. In one of the departments, they're not using face masks, or they're using masks, but they're not using face shields, they're using goggles. Resuscitation bags, pocket masks. Who here has a pocket mask?
This,
Yeah, I've got one of those, but no, that's not what I was looking at. I've got one in my bag, I'll bring it in after break. You should always have one. Anyway, that's a good standby one. So use, accessibility, cleaning, laundering, and disposal. Most PPE, I say most, how many times do you use them? Once. They are, or should be, disposable. You've been hearing words about people having to reuse their masks, or their masks being put through cleaning stuff, so yeah. These ones should be a daily one, should be use only. Repair and replacement. Normally the gowns are single use only. They shouldn't go into the laundry because they just come apart. They should be disposed. And where do you dispose of your PPE? What type of
Hazardous waste,
disposal? What?
hazardous waste.
And what does that look like?
big red bag.
big red bag, or a red bin, or a bin with a red bag inside of it. And it says biohazard on it, usually. But they're always red. Garment penetration. If you're using your PPE with a gown, a normal type gown, and you have a arterial spurt, what's that going to do to your gown? It's going to go right through, actually. So you may have to change.
So what if it's down for if they're not gonna touch you?
Well, it depends on how much liquid you get, because they're meant to be disposable. In a normal wear, yeah, the gowns are protective. But if you have an abnormal amount of blood, which you very rarely see in our department, thank goodness, it may go right through into your clothes. It's very rare, very rare. Like your bags, by the way, little FSCJ. They're cute.
They like stops doing when you're walking, well, you don't have to, but you stop when you're walking in and they'll say you want like a goodie bag or something.
Oh, okay.
I haven't even looked at it.
That's okay, I just haven't seen them before, that's all.
It closes at 11:30 if you want it.
No, that's fine.
They give you a mug.
Oh, good, okay.
Floor.
I just have never seen them before, but,
Same stuff as.
okay, so where were we? Okay, so PPE removal prior to leaving work area. So if you're wearing PPE to work, or you go into the department and you put your mask on, and they come in and they'll give you a face shield or goggles and a gown. At the end of the day, you don't go home with those. You take them off and leave them. There's one department in the city that's actually providing scrubs. So when the staff go in, they're given a pair of scrubs, which they wear during the day. They give them, everybody know what an N95 mask is? They'll give them that. They'll give them goggles. So that's what they wear every day. And then in the evening, they change out of the scrubs, put on whatever they're wearing to go home. Whether it's another pair of scrubs or, so that's what they're doing. Other departments, they're just wearing N95 masks and a face shield. Very much an individual thing. Worksite maintained in clean and sanitary condition, cleaning and contamination of items and safe disposal. Now, as I mentioned a little bit ago, a couple of weeks ago, I mentioned that this, in some departments, the cleaning staff are allowed to come in and clean the floors, but they're not allowed to touch anything on the counters or on the machine bed or anything like that. That's our way. We have to clean those. So if you have a problem, we have to do the cleaning. Unless it's a massive spill, like somebody vomits or something, then we probably would cut the cleaning staff in. But the machine, the bed, the counters around it, we have to keep clean and tidy. and safe disposal, all of the sheets. If you happen to, as happened to one of my colleagues at one point, she was taking the sheet off the bed, put it in the laundry basket, and she had knocked off her ID. It was on a clip, and the way she had pulled it, I guess it just caught, and it went into the basket. Yeah. So we thought about it and said, okay, these are supposed to be contaminated, right? So we decided that we would, so we all put on gloves and gowns, and we rummaged through the laundry to find her ID badge. Because without that badge, she couldn't get back in the morning, so.
So you did find it in there?
We did find it eventually, yeah. It was a good job she didn't notice it, or she did notice it before it went to the laundry, otherwise it would have been gone. Okay, contaminated sharps. So approved sharps containers. They're little plastic boxes that are on the wall. They say sharps. They have to be easily accessible, they have to be upright, and you do not overfill them. And when they reach, I think it's 3/4 fill, you have to call the disposal company and say we have a sharps box that needs emptying. And they will come with their fancy containers to remove it. We don't have reusable containers. They take away the sharps box and give us a new one.
What happens to all that waste?
It goes to a biohazard facility who, we hope, is supposed to sort it and dispose of it. I think they're usually furnaced. They're usually put in a furnace. So other regulated waste containment, obviously, you can either have a red container, which is a bin, or you can have a container with a red bag. So it says biohazard, which you would put your laundry in, or any of the dressings. Perhaps you take off a patient's dressing in order to treat them. That goes in the biohazard box. A disposal of all regulated waste shall be in accordance with applicable regulations. I believe that all biohazard, the soft waste, the other waste, is put into a furnace. So in 2000, it was estimated that over 300,000 percutaneous injuries would occur involving contaminated sharps. That's a lot. That's really a lot. Organization use safer medical devices, as we mentioned, need to reflect changes in technology that can eliminate or reduce exposure to bloodborne pathogens, and must document annually the consideration and implementation of safer devices. We have these needles now that it's almost impossible to get a needle stick, but people still get it, so. Sharps injury log. So department, work area, and how the incident happened, that's the incident form that you never want to fill out. Must solicit input from non-managerial staff and make sure that everything that can be controlled is controlled, and whatever can be done to stop it is done. That's something you see that we'll never see anymore, at least in healthcare, at least in human healthcare. This needle does not have a lock on it. Contaminated laundry, leak-proof bags or containers, and color-coded, they should be red. And as I say, most people will consider all laundry contaminated. And if you are somebody, depending on who removes your laundry, then the person who removes the laundry has to be aware that they have to use PPE. If you're in a large hospital, somebody comes along and takes the laundry from you. You put it in a bag, and there's a lock that goes onto the bag. You put it out somewhere, and someone comes along and takes it. And in some departments, they ship it off to an off-site facility. Hep B, obviously. You guys all had to have Hep B vaccines, right? Okay. No cost to the employee at a reasonable time. Licensed physician or healthcare professional has to be done according to recommendation of US Public Health Service. And they're all conducted by an accredited lab. So when you start work, you will again be asked to do a Hep B. There are some, not only Hep B, but other ones as well. What other vaccinations were you guys asked to do?
Flu shot,
Excuse me?
the flu shot.
Well, yeah, flu shot. What else?
Tetanus,
Tetanus.
varicella,
MMR.
MMR,
Okay. So there are some hospitals and or clinics in the area that will not employ you if you refuse to have a flu shot. You should remember that. In the department I worked in California, you were given the choice, but if you declined to have a flu shot, and this is several years ago, you had to wear a mask during flu season all the time. So that was from, I think it was October to May, that whoever didn't have a flu shot had to wear a mask.
It's like a scarlet letter.
Yeah, so you knew who were, you know, unless they were coming out of the OR or something, you know. Yeah, you know, you had the guys from plant services or from environmental control or whatever it happened to be, and they were running around with masks, and that was the reason why they had they had declined to have the flu shot. But other hospitals say, no, you don't have a flu shot, you can't work here.
I think there was one of our shots, and I can't remember which one that was optional. It was a flu shot.
Well, flu is not, it's
I
on
mean, I
our,
got all of them.
it's on our list thing,
Yeah.
the Compolio,
Yeah.
but it's not required yet.
What?
It's got a date on there,
What?
the flu shot,
The flu shot,
and COVID. Both of
Yeah,
them.
COVID's
the
on
flu
there.
shots have to be, the flu shots have to be done as soon as they come out, basically, because Normally, we start getting flu shots around September, October.
Aren't we supposed to have them before clinicals?
But if the flu shots aren't available, then you can't get them, right?
Yeah, I got one right before we came back.
Yeah,
Me too.
yeah. So everybody by now should have had a flu shot. Am I correct? Yeah. So, I mean, if you're starting in clinicals in May, the flu shot isn't available till October, perhaps. So you won't be able to get it until October. But I would imagine that you'll probably have to get a COVID, at least a test, depending on how quickly the vaccinations are done. But I would imagine that we may be able to get them, at least the test.
I'll take it anyway.
The way things are going, I doubt very much whether it'll get down to a sort of normal people plan. Oh, sorry. Okay, so post-exposure evaluation. So again, this is what we were talking about earlier. Documentation of the routes of exposure, identification and documentation of the source individual, which means the patient, collection and testing of blood for HPV and HIV, post-exposure prophylaxis and care, counselling and evaluation of reported illnesses. Information and education, so time and initial assignment, so this is when you actually get your job. You'll have all this stuff to learn. Hopefully you'll know most of it. Annually, they'll do another one. If changes occur, then they'll do another one. Content and vocabulary appropriate to educational level. Literacy and language of employees. What did we say that the normal healthcare information, what grade level should it be at?
7?
7th grade level. Okay, so this should all be given to employees who may be at risk for exposure at no cost to them. So it'll be all done by the employer. And they should be minimum requirements and program requirements. So medical records of the individual staff member, training records of the individual staff member, and the medical records shall be maintained for a duration of employment plus 30 years.
Wow.
So if you're only employed by somebody for 2 years, they have to maintain the record for 30. So I could call somebody that I worked for in El Paso, which was 2001, and ask for the records, and I should be able to get them. Training records. Maintained for 3 years from the date of training. But then, of course, that's upgraded, so it'll be 3 years from that date too. So, why do we not have 100% compliance? Lack of training is a big one. Busy, hectic, rushing. You're busy. The department's treating patients 1 every 15 minutes. You're doing the best you can, but that's the last thing you're worried about. decreased awareness of hazards. Well, at the moment, we have an increased awareness of hazards, right? Because we're all in this pandemic thing. And it won't happen to me. Yeah, okay. So OSHA, bloodborne pathogens, and what the employer needs to do. Questions on that? No? Okay. So let me think probably what we need. Okay. Okay, so let's take a break. It is now and we will back door, please. Thank you. Okay, so this is chapter 9 in your books. It is infection control in the radiation oncology department. What is infection control? Well, we've gone over that. It's control of the spread of infectious diseases and their causative microorganisms. What kind of microorganisms may we be talking about? Anybody? Microorganisms. What are we talking about?
Viruses, bacteria.
Say again?
Viruses and bacteria.
Viruses and bacteria. Or bacterium, yeah. And else? Fungus, okay.
I guess parasites too.
Parasites, yeah, could be. Okay. So epidemiology is the study of the distribution and determinants of disease and injuries in human populations. The epidemiology department is where a physician who wants to do research would start to see what the distribution of a particular, whatever he's studying, would be. Infection involves the reduction of a microorganism in the body. What happens if you get a vaccination for the flu? They do a vaccination. What does that do?
It's supposed to introduce the most commonly spread viruses to your system so that you're.
So you're putting in a virus?
Sometimes,
A dead virus.
sometimes it's the live version, sometimes it's non-live.
What are the flu vaccines normally?
Normally they're not live, I don't think.
No, they're not.
The nasal
Very,
is live.
very seldom do you get live vaccinations these days. The flu vaccines are dead. So you cannot get the flu from the flu vaccine because you're not getting, I think the last live vaccine used was for smallpox.
Good old military is still doing the nasal spray live versions. My husband used to
Yeah,
get it every
yeah,
year.
but that's,
So how come some people do get sick after they get the flu vaccine?
it's the reaction of the body. It's not the flu. You cannot get the flu from a flu vaccine. So it's probably the reaction of the body. Most people get a bit of a sore arm and maybe a slight fever, but that's it. Some people get more than that. That's just the body. And some people will be told it's all in their head. And some people, that's true. You're getting something, they think it's a flu vaccine, so I'm going to get the, But you cannot get the flu from a flu vaccine. It's the reaction of the body. So you may be more susceptible to how they make the flu vaccine. For example, they tell you not to get the flu vaccine if you're allergic to eggs. Why would that be? Because that's the way they grow the flu vaccine, is in eggs. So if you're violently allergic to eggs and you get the flu vaccine and don't tell them, you may have a reaction. So it could be that. Okay, let's get back to where we were. Disease is a collective term used to describe the signs and symptoms associated with an infectious agent or unknown etiology. So some kind of disease that you've probably never had before. So typical infection, clinical signs and symptoms, fever, pain, swelling, redness. And that's the body producing an immune response. Subclinical infection, no external signs or symptoms, the body does not initiate an immune response. So if you're starting an infection, you may get swelling, you may get red, maybe pain, you may have a bit of a fever. Infectious organism with no interaction between the body and the microorganism that would result in a detectable immune response. A person who is colonized but not ill is a carrier. So, if you develop the infection, you get ill to one way or another, you get sick. If you get the flu, what are the symptoms of the flu?
Fever, coughing,
Cough, chill,
chills,
Pain where?
everywhere.
Everywhere.
Yeah. Body pain usually. Muscle pain. Pain. Whatever pain, yeah. However, there are certain, so depending on what kind of infection you have, it would result in some kind of response from the body. If you've had that infection before, then you have what against that disease? Say again? Antibodies. So, for example, those of us who are too old for the MMR, I never got an MMR. It didn't come along till way after I was a kid. I'm still immune, well, I have antibodies because I got mumps, I didn't get mumps, but measles and rubella. We had what, and it sounds weird, and I know it's weird, but we had measles parties as kids. One person got measles, and the adults would say, okay, bring them all
That's
here.
how the chicken pox.
Chicken pox.
Chicken pox,
Yeah,
same thing.
that's what they do with the chicken pox.
Yeah. So every kid in the neighborhood got measles or chicken pox or whatever it happened to be. So we were all immune. Well, what? I know it sounds weird, and it sounds so stupid these
It's like
days.
if you're gonna get it anyways, might as well get it all at the same time.
And there was no vaccination at that point for it, so.
And you could fight it off probably better when you were younger.
Mhm.
Easiest way to do it.
Mhm. So,
Prepared for it.
yeah, so, however, there are certain people who can have the disease but don't show any symptoms. And they're called carrier. Can anybody give me the well-known one?
COVID.
Pardon?
They're all saying COVID,
No.
that you can have it, but.
And no, I'm not talking about that. There is a particular person in history
Oh,
that was a carrier but never had the disease.
Of what?
That would give them away.
Oh, then, I feel like I know who you're talking about, I just can't.
The lady's name was Typhoid Mary.
Oh,
You ever heard of that?
I've heard of her, yeah.
Yeah, so what happened was that there was a typhoid epidemic in New York in, I think it was the 1920s or 30s. And Mary was an Irish cook who cooked for a lot of the big households in New York. And everywhere she seemed to cook, there would be an outbreak of typhoid. So eventually what happened was, and she was fine. So eventually, cutting a very long story short, she was taken to an island in the middle of New York Harbor and left there. And, well, she was imprisoned basically in this small island in the middle of New York Harbor. And she died there eventually. But she was a carrier. And it wasn't until she actually was taken out of circulation, I guess you would call it, that the typhoid epidemic tended to sort of go away.
That's really weird that they.
But this was in the upper class. You know, there was the upper and lower. So the lower, there was always some kind of fever or disease going around, but the upper class usually didn't have the problem because they insulated themselves. But of course they had their servants, of which Mary was one. So her name now became synonymous with a carrier. And that lady's name was Mary, Typhoid Mary.
That's a true story.
It's a true story, yes.
They imprisoned a
You can
woman.
look it up, yeah. It's a true story. I'm not exactly sure of the dates, however, but yeah, it's a true story. Nosocomial infections are acquired, or normally are acquired, within healthcare facilities. But some of them do not develop until after discharge. So somebody who develops something like C. diff or MRSA would have acquired it while they were in hospital. But it might not have been noticed until after they got home. These days, however, healthcare infections or nosocomial infections are not as, they can be acquired basically in nursing homes, healthcare facilities, clinics, wherever. So they're not truly only hospital or healthcare facilities. So, regulatory agencies, CDC, Centers for Disease Control and Prevention. What's the CDC do? CDC has been all over the news in the last year. What does the CDC do?
Collects data, issues, guidelines, yeah.
Yeah, collects data, issues guidelines. What else?
Sure, they do testing and such.
They're the main clearinghouse for testing. They have labs galore in Atlanta. That's where if you find a new disease, for example, or a new type of disease or a new variant of a disease, it goes to the CDC in Atlanta. And they're the ones that give us the guidelines for COVID-19. We're supposed to all follow. Institute of Medicine, they're more of a clearinghouse. Joint Commission. Anybody not know what Joint Commission is? Okay, somebody tell me what the Joint Commission is. Only one person put up their hands to say that they didn't know where it was. So somebody who didn't put up their hands, tell me what the Joint Commission is. That's the other. Joint Commission is basically who regulates hospitals, along with OSHA. Now, OSHA is usually in charge of the staff part. Joint Commission is the patient care area. Joint Commission, along with OSHA, can actually shut a hospital down. If you lose Joint Commission status, you are not a hospital anymore. Or you are, but in name only. Good luck getting staff.
The Joint Commission, they only oversee hospitals, not private practice or.
They, in some areas they can, but mostly it's hospital-based systems. Sometimes what happens is that you have private practices that are attached to the hospitals, like the private practices that you see that are in the city that are that have the doctor's name and then it says Baptist Health underneath them, or UF Health underneath them. They would be included in Joint Commission.
So would that be any doctors who have privileges at a certain hospital they have to adhere to those positions?
They don't, if they do have privileges, but they're not part of the UF Health or Baptist. So they have to have an affiliation. Their clinic or their practice has to have an affiliation with one of the hospitals.
Is that true with OSHA too, or is OSHA
OSHA,
Everyone.
yeah,
any medical?
OSHA is just like jobs
anything,
in
anything.
general.
Anything.
Okay.
If you have an accident at work, on a building site, for example, OSHA will come in.
So even like Home Depot or.
Mm-hmm.
Yeah. OSHA can shut anybody down.
And that's a government agency, OSHA is?
OSHA, no. Neither of them are governmental. but they have their rules and regulations to match. Yeah. Both are independent. Both OSHA and Joint Commissioner are totally independent of government.
How do they get authority then? I mean, I guess I'm trying to figure out how.
They've been given authority.
So it's like you just invest in that, you know, in other words, if you're a hospital, you just agree to follow those.
Yes. Otherwise, you don't open. Same as Joint Commission. If you fail, Joint Commission comes in every 3 to 5 years. And the hospital pays for them to come in and check them, believe it or not. And if you've ever been through a Joint Commission inspection, yeah, it's hell on wheels. But they'll come in every 5 years and make sure everything is good. And then they'll say, okay, you need to fix this, you need to fix this, you need to fix this. Within 6 months. It could only be paperwork, but it has to be done. And after that, they'll give you, okay, we'll be back in 5 years to check you again. OSHA can come in at any time. If you see something wrong anywhere, a building site, Home Depot, hospital, clinic, whatever, all you have to do is call OSHA and explain that you've seen this.
How do they get their funding?
They have a grant from the government. So all you have to do is call OSHA and say, I noticed this in Home Depot, or I noticed this at Sam's, or whatever it happens to be. And OSHA will look into it, and they can appear anytime to actually make, to see what's happening. And they don't have to give warning either, they just appear. But if there's an accident, OSHA will come in. They have to be informed. Okay, so infection cycle can be broken at any point. So you have a pathogen, infectious agent, the host, direct or indirect, and we'll get to that in a little bit. If disease develops, you have, then you have a portal of exit, passes on. So if somebody develops common cold, for example, common cold, a bacterium, or whatever it is, what is it? What's a common cold? Pardon?
What is the rotavirus?
It's a virus, that's all I wanted to know, it's a virus. Rhinovirus, yeah. So basically, it's a virus. Why then do people insist on getting antibiotics? Because they're dumb. Yeah. That's why antibiotics don't work on people anymore, because they've been overused.
They don't give it to you anymore if you have just a virus.
No, they don't. But people go to a doctor and they say, I've got a cold and I'm feeling awful and I need some antibiotics. And the doctor will say, okay, here, just to quieten them down, which is the wrong thing to do. But that's what happens. Anywho, let's get back. Okay, so you have a cold. You sneeze on somebody. They have a cold. You've actually passed it on. Portal of exit. What's the portal of exit? For a cold.
Your mouth.
No.
Yeah, you basically sneeze on somebody or cough on somebody. And then you have transmission. And so it goes on. So a pathogen is an infectious agent. Pathogenity is the ability of an infectious agent to cause a clinical disease. And virulence is the severity of the disease. You've heard that some diseases are virulent. which means they're really, really, really infectious. So bacteria and viruses, they're the most common sources. Fungi, protozoa, algae, and prions. So we all know about bacteria and viruses. Give me an example of a bacterium. Sorry?
MRSA?
MRSA, okay.
Streptococcal B.
Strep, yeah. What about a virus? We already mentioned it. Rhinovirus. HIV. Fungi. Fungus infections,
Ringworm.
Ringworm.
okay? Anybody else? Okay. What is algae? Algae? Where would you get algae? Where would you find it?
Water.
Water, yeah. Protozoa? Sometimes in the water as well. What are prions?
I remember that from micro.
Say again?
I feel like I remember that from microbiology, but I just don't.
Has anybody heard of mad cow disease?
Yeah.
What is that?
The name of it, I would guess it affects your brain somehow.
Yep. It's a prion disease. And basically, it started off with, I know this sounds gross and silly, but it can be caught by people eating the meat of infected cows or meat of infected cattle. Or it can be done, especially the human one, of eating what we laughingly call sweetmeats, which are, has anybody heard of sweetmeats? Brains. And people do eat them, believe it or not. No, thanks. I may be dumb, but I'm not stupid. No, some people it is a delicacy, believe it or not. So that is a prion disease. And these are parts of it, and these may look like normal diseases, but they're not. The chlamydia and the rickettsiae are not anything to do with chlamydia or rickets. They are prion diseases. Okay, so the host. Disease develops, host goes through 3 phases. Incubation. So the time interval between exposure and the appearance of the first symptom. And that can vary from hours to days. In measles, for example, you're actually infectious, you're actually infectious before the spots arrive. So, incubation period. Clinical disease, patient or person exhibits signs and symptoms. So, we'll go back to the common cold. The incubation time between exposure and the first symptom. Maybe hours, maybe days. Clinical disease. So depending on how long it takes for you to recover, and then convalescence, stage of recovery from the illness. That can vary, all of these can vary depending on the disease that we're talking about. In some diseases, the incubation period can be 20 days. Unfortunately, that incubation period means that they're probably infectious. And just because they're not showing symptoms doesn't mean to say that they're not infectious. So, for disease to be passed to others, a portal of exit is necessary. So, respiratory tract. So you're coughing or sneezing. Gastrointestinal tract. What would that be? What would be the portal of exit? What?
Throwing up or diarrhea?
Yeah. So what's the correct phraseology for throwing up?
Emesis.
Emesis, yes. And for diarrhea, it's diarrhea. Defecation, okay? So you're either throwing up and having diarrhea, both of which can be exits. So you have to be careful with the emesis of a patient or the feces of a patient. And you have blood and you have skin. Blood is obvious, right? You're bleeding. Skin. How would you get it through the skin? Sores? Okay. So you're talking about pustules or something like that? Okay. What about if you don't have pustules or something like that? That also has skin lesions, so we're saying that they don't have any kind of skin lesions. If they're having a fever, what happens to the skin? If you're having a fever, what's the skin look like? Are you warm and dry, or are you sweating buckets? So if you touch the skin and you're sweating, that might be an exit. Okay. Transmission, defined as the movement of an infectious agent from the source to the host. So you have several routes. You have contact. I come up and touch somebody and they're perspiring. That could be a transmission route. Droplet. Where do you get droplet? Sneezing, coughing, breathing, talking. Some people, if they're talking, they're spitting. You know? Have you ever come across somebody like that who talks and spits at the same time? Thank goodness for masks these days. Okay. Airborne. Airborne. What would that be?
Smaller particles that get carried.
Smaller particles, yeah. So they can get carried for how far?
Smaller they are, I guess, the further they'll go.
Smaller they are, the farther they'll go. So you're talking about 6 feet, 10 feet, whatever it happens to be. And vector-borne. What the heck's a vector?
Insects, mosquitoes, ticks.
A vector is what?
Any critter that can bite you and give you the disease.
Okay.
Ticks can give
For
Lyme
example,
disease.
the mosquito. So give me an example of a mosquito-borne disease that is not malaria.
West Nile virus.
West Nile, yeah, West Nile virus. Where do they come from? Where does the West Nile virus usually come from? Pardon? Deer ticks, usually. There's another one which I actually printed out something that I found online. It's called the hantavirus. Has anybody ever heard of that?
I've heard of it, I don't remember it. but-
Okay, the hantavirus, they first noticed it, I think, in 1960s. And it was in the southwest states of the US, and primarily in on the Navajo res. And they were noticing that some young, fit, healthy people were dying. They were getting this disease, which seemed to be a flu-like disease, and they were dying. And eventually what they decided it was the mice on the res that were carrying this disease. And it was the droppings. So they weren't picking droppings up, but they were breathing in the droppings or the air from the droppings. And that was what was making them sick. So it usually is in the desert southwest. It's usually dry areas.
Wasn't Legionnaire's disease something like that with like, air ducts and?
That was Legionnaire's disease, and that was done, I think, in Miami. It was found, and it was actually it was waterborne, that one. And they called it Legionnaire's disease because it was first found in a group of Legion American Legion guys that were having their having a yearly meeting, and that's why they call it Legionnaire's disease. So contact can be direct or indirect. Most frequently spread by nosocomial infection. Host makes physical contact with the source, touching someone after touching another who's had a disease. Indirect contact involves an intervening object that is contaminated from an infectious agent. Needle stick would be one, but if they touched the table and then someone else came along and touched the table, then that could have been. Droplet, sneezing or talking too close to someone's face. Rubella, colds, influenza are commonly transmitted. So you're coughing, you're sneezing, you're talking in somebody's face, which nobody does anymore, thank goodness. And of course the mask helps. So droplet. Common vehicle spread. Transmission involves a contaminated inanimate vehicle known as a fomite, for transmission of the infectious agent. So fomites include water, food, medication, medical equipment, and supplies. The common vehicle spread, all people are infected with a common fomite. And airborne. This is where the 6 feet comes in. That we're all so sick of hearing about. Airborne transmission involves an infectious agent using the air as its means of dissemination and involves a long distance, which is typically described as 6 feet or greater. or even miles away. So vector, mosquitoes calling malaria, carrying malaria. Ticks carrying Lyme disease or Rocky Mountain spotted fever. Other diseases are carried by fleas, ticks, bats, rats, mosquitoes, and other vermin. So the most common one, of course, is the mosquito carrying malaria. And useless piece of information, it's only the female mosquito that carries malaria. But even. So Lyme disease and Rocky Mountain spotted fever. Defense mechanisms. Body comes with defense mechanisms. Skin, cilia in the lungs, acidic lining of the gastrointestinal and urinary tracts, tears and saliva. Specific defense mechanisms, two forms are natural immunity and artificial immunity. Natural immunity develops as a result of acquiring the disease. So I have a natural immunity to measles because I had it. I also have one to whooping cough because I had it. And rubella because I had it. Chicken pox because I had it. Artificial immunity is the active immunity consists of vaccines altered with the pathogen, and passive immunity consists of the transfer of protective antibodies from one host to a susceptible host. So active immunization basically is what we give for the flu. The vaccine triggers the antigen and triggers the human body's immune system to create antibodies. Antibodies are specific and work against only a specific antigen, and antibodies are known as titers or titers. So that's when you go and you get the blood test done and it tells you, yes, you have titers or you don't. If you don't have immunity. If you do, you do. Airflow, temperature, humidity influence the cycle of infection. Other factors include carpet, upholstered furniture, fresh or dried flowers, potted plants, fruit, or linens. Previously mentioned factors create a home-like atmosphere, but are a breeding ground for bacteria and spores. So you go into a doctor's office and you have luxurious furniture, you have couches and you have chairs and you have upholstered furniture. Looks wonderful. Doesn't do any good though. So you shouldn't have upholstered furniture in the hospital or in a clinic or in definitely not in a radiation therapy department or a cancer center for that matter. So what do our patients have, or what is the problem with our patients when we're talking about infection control?
They're immunosuppressed, I guess, right?
A lot of them are, yeah, and that's the problem, especially if you have a patient that is being given chemotherapy. Chemotherapy, unfortunately, knocks the heck out of the immune response. So the majority of our patients who probably have had or will have chemotherapy are immunosuppressed. So any kind of infection may cause problems with our patients. So that's why we love the fresh flowers and the chocolates and the potted plants and everything else. But it's not really good for our patients. It may make them feel better and feel good to see flowers around the department, but it's really not that good and we shouldn't have them. And for the interior designer who thought that our new, when I was working in Canada, we had a brand new center open up, gorgeous place, absolutely beautiful. But the interior designer decided it was a good idea to put carpet in the treatment area, all of the treatment areas. So it was wonderful and the patients loved it, but you can't keep carpet clean when you've got people wandering in and out. And if somebody accidentally pees on the carpet or throws up on the carpet or whatever they happen to do on the carpet, it's an infection waiting to happen. It looked wonderful, but there is one spot in that department that we had a patient who had what they call a chemo spill, and it took the color right out of the carpet. This was chemotherapy that was going into patients' veins, and the bag had a little hole in it and it was dripping and it went onto the carpet and it took the color right out of the carpet. So it just shows you what they can do to the veins. But yeah, so that's the kind of thing that we don't allow anymore. But that was, we moved into that department in 1985 and it probably had been designed about 1982-ish, they were about. So that and the color scheme was orange and avocado. Oh, well, it was nice in the late 70s, early 80s. That with the colors, that was the in thing. It got a little strange around the 90s. Yeah, orange and avocado. Anyway, so environmental factors, custom-made bite blocks. So I have one here, I believe. This is a bite block. What do we, first of all, we'll do this afternoon. We'll explain what a bite block is this afternoon because we're starting on head and neck this afternoon. So custom-made bite blocks, we'll deal with that this afternoon. Just remind me. Treatment table and slide boards. Remember we talked about slide boards last Wednesday and how we move the patients off and on. And the treatment tables. What do we have to worry about with these treatment tables and slide boards? We're moving patients around on them.
Not being stable?
Pardon?
Like not being stable?
Not being stable. Okay. What about infection control wise though?
Oh.
Yeah, you're good. Yeah.
Not being sanitized?
Yeah. So you've got patients who come down in these strange and wonderful hospital gowns, right? Do they have anything underneath the hospital gowns?
No.
Okay. So hopefully they have a sheet on the underneath them that we can slide the slide board underneath so that we're not got the butt on the slide board. So we've got a sheet over top and we just pull them over. However, they have to be cleaned after every use. So we swab them down with usually a bleached wipe or something, Clorox wipe, something like that. Same with the tables. We use bleach, but we always put a sheet on the table so we can just get rid of the the linen. Tattooing or placing permanent marks on patients. So in some departments, we use tattoos. In most departments, we use tattoos. How do you make a tattoo?
With needle.
With a needle. Okay, and? Ink, Indian ink. Yeah, so there are special types, and I'll show you them this afternoon. I didn't bring it in. It's what's called a stereotat. And basically you put the ink on the bed, you put an ink on the patient, and you just basically dig the needle in, or put the needle in, and let the ink go underneath the skin. And if you do it right, it's smaller than a freckle. And you put 3 of them on. 2 on one side, 1 in the front. Bolus sheets. Bolus is, what is bolus?
The stuff we use to adjust the depth of radiation to the level that we want, like fake flesh.
Fake flesh, okay. The official name is tissue equivalent material, okay? You should use that, face flesh, doesn't right. Anyway, so it's called tissue equivalent material, and it can come in various forms. Normally, if you use it, it is a piece of, it looks like, it's called superflap. And it looks like wax, like beeswax. And you can use that for several people, but you have to cover it. Make sure it's covered. How would we do that? Make sure it's covered. How would we cover it and still be able to use it for individual patients?
Disposable paper sheets. Regular sheets.
No, we don't use it regular sheets because regular sheets, it wouldn't stick to the patient. It would just slide off. So we use saran wrap, believe it or not. And we wrap the saran wrap around the bolus and we put it on the patient. And then for the next patient, you take off the saran wrap, wipe it down, and put another layer of saran wrap on for the next patient. Pen or marker used on a patient. So if we don't, even if we do use tattoos, we have to mark the patient every day anyway, or 2 or 3 times during the week. What do we use? What kind of pen would you think we use? Pardon? Sharpie. Yeah, we use a Sharpie. So do we use the same Sharpie on several different patients?
No.
No? Why not?
Cross-contamination.
Cross-contamination, yeah. So what happens, what should happen, is that each individual patient has their own Sharpie. So what happens is that you go into CT, the marks are put on the patient, and then the patient's name is put on the Sharpie, and it goes with the chart to the treatment machine. So you have this bundle of pens, all for each patient. So you have Mrs. Smith's pen or Mr. Jones's pen or whatever it happens to be, and you use them only for that patient. And when they're finished, treatment totally, the pen gets thrown out. And you never, ever, ever use somebody else's pen on another patient, because that gives you cross-contamination. Thermoplastic masks and the water baths used to make them. All of these masks, except the 3 on the end there, well, no, 2 on the end there, were made using what is called a water bath. And what that does is you have basically a hot water tank. You put the solid mask into the water tank, and it heats it up and it becomes malleable. You take it out and you put it on your patient, as you saw in some of the videos. So, what kind of infection control does that cause? What infection problem does that cause? Anybody?
Sanitization issues,
Who? What?
sanitization,
Sanitized, okay. In what way?
probably needs to be cleaned after each use.
The water tank?
Not the water tank, the masks.
Oh yeah, the mask, yeah. But remember, you're using it just on one patient. So that's Mr. Smith's mask over there. You don't use it for anybody else.
So is the water tank, do you have to reheat sometimes, take them off their face and reheat them? or-
No, never.
So I don't know why you would have to, I guess your hand, I don't know, touching the water, I don't know why you'd have to get rid of your water, do you have to?
You don't have to get rid of your water after each patient,
Okay.
but you do have to clean it once a week. Because you've got 2 or 3, you've got, in a week, you may do 10 or 11 masks.
You're putting your hands in.
And you're putting your hands in, or actually you're putting, not your hands, but tweezers to get them out because they're kind of warm. But you're putting individual masks in and they're going on individual patients. So there is a little bit of cross-contamination going on there. So these water baths should be cleaned and sanitized once a week, at least once a week. Now, what we're doing, we don't have a water bath, we have an oven, which we are going to use to make masks. So it's not quite as bad, because it's dry heat. It doesn't have the problem.
Just out of curiosity, when they're done with treatment, do you throw away their mask or do you give it to them to keep?
We
or-
give them the choice. They can either take it home or we can throw it out. We usually destroy it. Actually, what we normally do is remove, because they usually have some kind of name on their masks, we take that off and then we just throw it out. But we give the patient the option, and a lot of them want to take them home. That may surprise you or not, but a lot of them want to take them home.
My dad took his home. I used to play with it. I didn't know what it was.
Yeah. We had one gentleman who wanted to take his mask home to scare his grandchildren on Halloween. Whatever, you know. We had another lady who had a large mask rather like that, and she lined it and used it as a planter and grew potted plants in it. Whatever you want to do with it, I mean, it's theirs. So that's so antibiotic use for more than 60 years has caused the organisms to change genetic makeup to resist antibiotics, and that's partly because they have been misused or overly used. And many people have you heard saying, well, I've got 10 days of antibiotics, but I felt better after 5, so I stopped using them. Yeah? Overuse of antibiotics by physicians, wrong antibiotics being prescribed, patients demanding antibiotics for viruses and stuff, and patients not finishing antibiotics are all contributing factors to the rise in new pathogens causing nosocomial infections, hence MRSA and C. diff. And also there is a type of TB that is antibiotic resistant. So there's only, I think, 1 or 2 types of antibiotics that will work on this particular strain of TB. Okay. So healthcare facility, to be accredited by the Joint Commission, hospitals have to have an epidemiology division. State laws govern reporting of specific diseases and disposal of medical waste. OSHA focuses more on healthcare workers. Hospitals are being mandated to have employees undergo physicals, epidemiological health and safety orientations, TB testing, and infection control quality assessment or improvement programs. So when you get a new job, you'll be faced with these books. One set of books is policies and procedures. The other set of books is infection control and quality assurance. And you'll be told to sit there and read them. Okay, so hepatitis B. Vaccine became available in 1982 and it's recombinant DNA. Influenza, MMR, varicella, and tetanus, diphtheria, and pertussis, TTP. Diphtheria is almost totally gone now. But I guess they still need to do it. What's pertussis? What's the other name for pertussis?
Whooping cough?
Whooping cough.
Oh,
Yeah, whooping cough. So no effective vaccine exists for TB, and the multi-drug resistant TB can be fatal. Primary transmission of TB is airborne droplet. Exposed 5 to 10% actually develop TB. And OSHA mandates minimum level of respiratory infection, N95 half mask respirator. So not the I-95 mask, but the actual I-95 respirator for TB. We probably would never get a active TB patient, but it has been known for one to slip through. So a person who has positive test is at risk for developing active TB even years later. Treatment is encouraged before active TB presents. So, usually what we use is a MAN2 test. That's the one where you get the skin check, and if it comes up, you're positive, it doesn't do anything, you're negative. That's the one which most people use. Okay, other diseases that require healthcare workers removal. Conjunctivitis. Everybody knows what I mean by conjunctivitis? Yeah? Okay. Epidemic diarrhea. Streptococcus. Hep A. Herpes simplex of exposed skin. What does that mean? Herpes simplex of exposed skin. Anybody?
Like cold sores?
Yeah, it's a cold sore. Measles
So
and
healthcare
mumps.
worker would be removed from working with a cold sore?
Depending on the policy of the department, could be. So we're down to mumps and measles, rabies, Staphylococcus aureus, varicella zoster, pertussis, and rubella. Hopefully you'll never have rabies, but
If you do, you're pretty much, it's got the highest mortality rate of any disease.
yeah,
Right.
but there is vaccinations for it, sorry?
Why is the varicella zoster, it says most critical radiation therapy department?
What is it?
The chickenpox?
Almost,
Shingles. Oh,
Exactly.
Okay.
yeah. There's, it also has, shingles also is a sort of, being immunocompromised makes it even worse. And as a lot of our patients are immunocompromised, they can get nasty shingles disease. So major source of nosocomial infections, respiratory, virus, so direct contact via large droplets over a short distance, airborne transmission, small droplets that can travel far distances, and self-inoculation after contact with contaminated materials, transferring the virus to the mucous membranes of the eye or nose. That's why you don't get, somebody don't get this. You shouldn't do that just after it. Okay, whatever. Common cold, croup, and viral pneumonia are caused by the influenza virus. Vaccine effectiveness ranges from 60% to 90%. Flu shots never cause the flu. Okay. It is impossible because the vaccine is made from a killed virus. Should get flu shots early in the flu season for greater protection. Let's leave this till next week. We'll start on universal precautions next week. Okay. Let's finish here, and we'll see everybody